joining us to talk to us about the Health Data Research Network and multi-regional research. By way of background, Dr. McGrail is a professor in the School of Public and Population Health at UBC. She's also the CEO for Health Data Research Network Canada, which is a network of data centers and organizations that are focused on advancing multi-regional research with administrative data. And she's going to give us a little bit of an overview of that work and lay the land for some broader context. And with that, I'll hand it over to Dr. McGrail.
Okay. Thank you so much, Nathan, and sorry about the technical glitches there. I'm really pleased to be here and have the opportunity to speak with you, and I'm going to touch lightly on a number of things because I think I could talk about these topics for a very long time, so I'll try to keep it brief so we make sure we have lots of time for questions at the end if you want to dive into any particular things I'm talking about. I just did want to acknowledge the land that we're on now, which I believe it's Treaty 11 and Treaty 1, sorry. It's 2 1s. Sorry, Treaty 1 territory and of course unceded traditional ancestral lands of many different nations and communities and peoples. And I've in the few days that I've been here, I've been really struck by the fact that this is a confluence and a meeting place, particularly around the Human Rights Museum and where the rivers come together. And so it's really nice to have the opportunity to kind of help carry on those traditions with this meeting here today. And I am from British Columbia, which is, and my home is based on the traditional ancestral unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations, the Coast Salish peoples. It's a privilege to live there, and it's a privilege to be here with all of you today. So, I don't have any conflicts to declare. I have 3 kind of basic sections of things that I want to go through with you today. First is a little bit on the Pan-Canadian Health Data Strategy, as I think it just sets a broader context in which our organization is working. I'm going to do a little whistle stop with the Health Data Charter, which is one of the recommendations that came from the Pan-Canadian Health Data Strategy. And then I'm going to spend the last bit of time talking about Health Data Research Network Canada and the kinds of things we're doing to try to support multi-regional research. I'm also going to just stop and say, if anybody notices my glasses and the missing arm here, it's not an avant-garde style process. Actually just broke while I've been here this week. So there we go. Okay, so Pan-Canadian Health Data Strategy. Who here has heard of this or knows a bit about it? Okay, so some, not everyone. So these are headlines that were popping up in the very early part of the pandemic, and they really just are sort of setting the stage for saying that there's a really big problem with health data in Canada, both what we don't have that we should have, and then our ability to organize them and use them collectively within provinces, and then our ability to share them across provinces and territories for Pan-Canadian view of things. So there were a lot of conversations around this and lots of conversation and critique within the media space as well. And based on that, the Public Health Agency of Canada decided that they needed to invest in and support the development of a Pan-Canadian health data strategy. And one part of the work that they wanted to do in that area was to assemble an expert advisory group, which they created in December of 2020. And the idea was that a broad range of experts could come together and help put together some thoughts on how do we get past these very complex barriers to being able to use data, both within provinces and territories, but more fundamentally, the view of the Public Health Agency of Canada was across provinces and territories. So the mandate of the expert advisory group was to provide advice. It was not given the mandate to write the Pan-Canadian Health Data Strategy, but it was hopeful that they could influence what would come out in that strategy in the end. And the members had a very, very diverse experience. They came from First Nation, Inuit, and Métis organizations and communities. There were lawyers, people who've worked at Statistics Canada, people who work in the health information management space, people who use data for research, all sorts of, and members of the public as well. So lots of different perspectives. I was very fortunate to be one of the members of this group. It was a really rewarding experience and a really impressive set of colleagues that I was able to work with. And I think it's probably important to say we did not always agree on everything. That's probably a very, very good thing. Like, that's a healthy space to be able to work in. The chair for this group was Dr. Vivek Goel, who is really renowned public health physician, and now during the course of this time we worked together, he transitioned to become the president of the University of Waterloo, is very invested in the health data space, and was an incredibly able chair for all of us. So there were 3 reports that were written by the expert advisory group. The first was kind of, the theme was, why is this time different? Like, we've had 60 years of conversations about data, data issues, data problems, politics of data sharing. So we're going to venture into that space that others have tread before us. Why would it be different this time? So it was kind of an analysis of what people had suggested before and where those things might have fallen short and why. The second report was really about the foundations we need to have in place to have a really good functional health data system in Canada. And then the third report was a set of 10 recommendations for how we might be able to move forward. And it's that one that I want to actually spend a bit of time on. But I'm happy to leave these slides, and the links to those reports are here. They're not long, not technical, good reads. So this is the current state. I think in this crowd, I probably don't need to dwell on this at all, but the idea being here that there's a lot of, when we say health data, that's not actually a simple or straightforward thing. Like, what do we mean by health data? Do we mean clinical care? Do we mean certain sectors of the health system? What about the social determinants of health? What about other things that might affect or influence the way you interact with health systems or your ability to benefit from the healthcare services that are provided? So there's all of these different things, and I'm calling this the pizza diagram. I think it's because those things look like pepperoni, some of them. So, but the idea here is that there's all these different sectors, and there's locks and blocks between the ability, even in the consideration of providing clinical care, to bringing those data together. So this is the foundation that we're trying to fix. This is a really problematic state of being. So the recommendations, what I'm going to do is just give you the first couple recommendations, and then I'm going to go to the Health Data Charter, because that charter kind of encompasses the rest of them. The first recommendation was this idea that by 2030, we really need to have this fixed. And I mean, ideally, we would have it fixed sooner than that, but I think this is a more realistic idea, that we could get this done by 2030. And it's really kind of grounded on this, fixing the foundations, getting into a place where we can actually think about learning health systems, so continuous improvement, using every interaction with the health system to help make healthcare services better, to help make public health services better, so the people that come behind us will receive better, more comprehensive, more equitable kinds of care. And that this would all be guided by common principles that are articulated in a health data charter. The second recommendation, and there's a reason that that first one is the big vision, and then this one is the second one, which is that we must take a distinctions-based approach to supporting Indigenous sovereignty and Indigenous data sovereignty as well. And very much based on distinctions-based, meaning it needs to be different the way we do this with First Nations, Inuit, and Métis peoples, communities, and organizations. And really, this is about nation-to-nation relationships, grounded in the fact that Canada is a signatory to the United Nations Declaration on the Rights of Indigenous People, but also has legislation that says that we need to align our policies and laws with those principles. So then the Health Data Charter. We decided that we would put a Health Data Charter together because the thinking was, we really need to make sure we're all rowing in the same direction, that we have some common agreement on where we're trying to aim and the principles that would undergird a fully functional health data system. And so it's aligned again with the idea about the duty to put persons and populations at the center of things, but it's consistent with the idea of human rights as well. So the 10, and I'm going to go through this pretty quickly because I want to spend lots of time talking about Health Data Research Network Canada, but the first and fundamental piece is that health data systems need to be designed to be person-centric. So right now, I would say that they're either provider-centric or institutional-centric, and we really need to shift that so that we make data-based or decisions about data organization, data collection, and use that are really focusing on how does this help individual people either navigate their healthcare services or to understand how we can improve those services to support innovation and so on. We need to make sure that we have common standards, and this includes for terminology, health data design, but also for things like stewardship. We have a very, very different approach to stewardship. We talked a lot about the culture of locking down data. If our duty is to protect data, then maybe it's better just to keep them in a dark room where no eyes can see them. And we want to shift that to this idea that stewardship means you have a responsibility to keep data safe, but you have a responsibility to use them to help make improvements as well. And then there's also, of course, things like interoperability, so that we can actually, that's what allows us from a technical standpoint to move data from one system to another. But we also recognize the importance of human interoperability too, because this is really a lot based on relationships and trust and the ability for people in different sectors, in different provinces, in different territories to work together with this common understanding. So that was a really important one. Of course, quality, security, and privacy of health data needs to be respected at all times. We need to think about timely accessibility, and this is both, again, for clinical care, also for research purposes and so on, but also for people to have access to their own data, which is a real big lack here right now. I don't think there's very many places that have anything close to something that looks like a place where you could actually go get all of your health data. We do want to support the use of health data for policies, programs, statistics, and things that are aligned with the public good. We want to make sure as well that we're supporting data-driven social and technological innovation in a context that also requires that public good, but this is saying that we can't rule out the private sector and partnerships with the private sector to make all of this happen. We all depend on new developments in drugs and surgical techniques and all of those things, so we do need to have safe ways to be able to work with private sector and all of that. I think that there's a lot to be done in the space of health data literacy, and this is about the public, sure, but it really is also about providers, policymakers, and researchers as well, which I'll come back to in a little while. We'd like to see harmonization of health data governance and evaluation and policy. Harmonization does not mean that we're going to require every province and territory to have the same privacy legislation, for example. That's a very unrealistic or extremely long-term goal. But we could actually at least harmonize them so that we understand that where they say the same things and what those things are allowed, not allowed. Again, the support for First Nations, Inuit, and Métis data sovereignty. And we roll this at the end, kind of going back to that person-centered view of things, where we think it's important to include diverse members of the public and patients and communities and other stakeholders in the way that we design health data standards in information systems, how we think about who can have access to what under what circumstances, that there needs to be a continuing public voice into that. Because, and I won't say more about this as a whole different topic that I could talk about for quite a while, but this idea that when we're talking about these things, we're talking about values and norms. We're not talking about something that we could sit down and write a model and say, okay, this is the perfect way to run your health data system. You have to know what you're trying to achieve, and that really needs to be informed by what people expect, what they would like to see, and what they feel needs more guardrails or shouldn't be done at all. So that's the Health Data Charter. So with that kind of larger vision and view of things, I'll now come down and talk about Health Data Research Canada and what the kinds of objectives we have and the actions we're taking to try to make things better at least within the space that we can operate and have some influence. So I'll start with a little bit about who Health Data Research Network Canada is. It is a collection of organizations that might be data centers, or they might do things that are related to supporting or training in the use of health data. that came together many years ago. It actually started working together in 2015 with this common idea that we could do more in Canada, that we have a natural laboratory, that we could learn from policies and differences and similarities across our different provinces and territories. And of course, there's also some things that we just want to be able to analyze and understand at the pan-Canadian level as well. We had the opportunity to respond to a CIHR open call for proposals to help build what they called the Canadian Data Platform. And so that's when this group formally came together and started working together. We received that funding in 2019. We incorporated as HDR in Canada in 2020, and we have been working together under that funding since. And maybe I should just underline that while it's called the Canadian Data Platform that we're building, we are not pulling data into a central location. We're not building central infrastructure. In fact, it's quite a bit different from that. So our vision is that data across Canada can be used to drive improvements in health and health equity. This vision was specifically designed as something that we are really invested in, but we recognize we can't do this on our own. What we really want to make sure is that we can work collectively, collaboratively with all sorts of other agencies and groups and people who also have this vision, because it is going to take quite a lot of different players to make this all happen. Our specific mission within that broader context then is to bring together people, organizations across Canada for transformative and world-leading health data use. So this is that we're doing really innovative things, but that includes both things that we should do faster and things that we actually need to do quite a lot differently than we've done in the past. So there's a number of values and principles that underpin the way we work, and I thought this was important to bring forward because this really speaks to how our very diverse pan-Canadian group of organizations work together, because that was probably too small for you to see, but we really do have groups from every province. We have 2 territories involved. We're working on some partnership with Nunavut now, which would be all 3 territories, plus Statistics Canada and the Canadian Institute for Health Information are all part of our network. So we have these 5 values that embed some principles. So collaboration, one of the things that we aim for is that we have equity and participation from all of our member organizations. Again, we're not trying to build something central, and our belief is that for this initiative and our network to be strong and enduring, it needs to have that investment and support from every one of our member organizations. One is not more important than another in that kind of fundamental level. Trust is another of our values and principles, and that is the idea that we're trying to both earn and then maintain the trust of our multiple stakeholders, and that's internal to our network and, of course, external to our network, and naturally includes the members of the public as well, because, of course, the data we're talking about are largely public data about people. We are creative, we hope. This one was a really hard word to kind of figure out what we wanted to say, but the idea here is that we really want to be open-minded, responsive to things as they evolve, innovative, but of course within context of all the other principles and values that we have. We're trying to both align our work with what our existing best practices, but then also show some leadership and advance those best practices as well. So that's the excellence part of things. And then, sorry, the last one should be respect, not trust. That's a slide error. So, and the idea here is that we don't expect you as a member organization from an internal perspective to have a certain set of principles or a certain set of rules. We take people, provinces, territories, data centers as they are, hope that by working together we'll come to some greater convergence of the way we do things, but there's not an expectation that you have to change something about your current practice in order to become a member and work with us. So that is really about that sort of respecting the local policy context, respecting, and of course that applies to respecting the public's and First Nations, Inuit, and Métis values and principles as well. This, I don't want to get into organizational charts or that sort of thing, but I thought how we work together, the important thing here really is this piece at the bottom that shows that we have divided our work into working groups and teams. And so we have teams in the area of working on things like algorithms and harmonized data, and the Data Access Support Hub, Indigenous engagement, inclusion, diversity, equity, and accessibility, public engagement, privacy, modeling and informatics, and then our newest working group is in pragmatic and clinical trials. I want to point out as well here that there's a lot of leadership coming from Manitoba in this space, including Nathan Nickel and Amy Fryer, Charles Burchell, Lisa Licks, and Alan Katz have all been quite involved, and then there's a number of other people who have been brought in to work with us in Manitoba as well. So well represented here and really valued colleagues. The other reason I wanted to mention this is because I'm going to now go through the 5 objectives we have and show some of the things that we've achieved. But it's really about working across these working groups that we've been able to do a lot of the things that we're doing. So this doesn't map necessarily to those working groups. But here's the 5 objectives we have. This is probably the most pertinent to people who in this room are interested in doing multi-regional research, and I hope you all are. So the idea here is to develop and improve services and supports for data access. So one of the things that we recognize, of course, is that it's really, really hard to do multi-regional research right now. You have to negotiate with multiple different players. They have different rules. They have different expectations. There's all sorts of forms to fill out. It's a lot to manage. And so we have been working really from the very beginning. This was the very first initial focus to everything we could to understand those differences and then to provide services and tools and supports that would decrease that complexity and decrease the amount of time that an individual researcher has to spend doing all of that negotiation and toing and froing. So one of the first things we launched was this data assets inventory. So this and all of these things are online. They're searchable. They're hopefully easy to use. If they're not, we'd want to hear your feedback on that sort of thing. The data assets inventory is an inventory of data that are available for research requests. We usually put things in there where there's at least 2 provinces or territories that have that data, so it is kind of in this context of multi-regional research. And the data assets inventory has more than 550 data sets in it, and about 370 or so of those are things that you can't get through Canadian Institute for Health Information or Statistics Canada. So it's a wide range of things that are there. There's also an algorithms inventory. This is one of the first things that Lisa and the group that she's leading with Algorithms and Harmonized Data put together as a comprehensive, systematic review of all the publications out there that have actually validated measures that have been for multi-regional research. So it had to be, say, a chronic condition kind of definition or something like that that was at least in 2 provinces or territories in the publication, and it met sort of the test of quality and validity, and if it met all those criteria from the systematic review, then it's in our algorithms inventory. So the algorithms inventory currently has about, I think, close to 180 algorithms, which is probably lower than some of you, if you work in this area, than you might have in an individual provincial basis, but pretty solid starting point when we're talking about things that have to be validated across multiple provinces. We have consent information, so if you wanted to collect your own data and then get consent to link it to the information that is held in the routinely collected data sets within our member organizations, that we have put together a consent toolkit for you. So what we did was we reviewed all of the legislation and all of the expectations around consent language in our participating provinces and territories, and then from that derived what you needed to have for a comprehensive view, so something that would be acceptable given that you're working across multiple regions and territories. So what I would put together in BC might not meet all of the tests of another province. So this is a way to give you some confidence that your consent form will work when you get to the point of wanting to do data linkage. And then, of course, part of what fed into that is we've done a privacy review across provinces and territories. So this is looking at all of the legislation that's relevant to health data and including the movement of health data from one province or territory to another. So we have an understanding of what's allowed, what's not allowed, why that might be given the legislation. And this, again, is just, it helps us understand what we might be able to do as a network to help mitigate some of the complexities, because the legislation actually does have some quite different expectations, like some provinces only being able to move data out of provincial borders in the case where there is consent, which of course in our routinely collected data often, or usually, there isn't direct consent from people who are in those data. Again, all of these things are on our website with lots of detail behind them, so you can dig into anything that might be of interest. We've also done a lot of work to create some centralized tools. So there's an intake form if you just want to say, I'd really like to do this study and I'd like to know which provinces I could do this in. I'd like to know whether what I'm talking about is even feasible. I'd like to know how much it might cost. You can come do an intake form. You have a conversation with a DASH person, the Data Access Support Hub staff, and we'll provide an answer to that question. We can give support letters for grants that are going into CHR or other funders to say how much it would likely cost to get access to the data in these various places, understanding that we don't charge, but all of the individual data centers do charge. We're not charging for our services because we're fully funded through our grant from CHR right now. And then there's a data assembly plan, so this idea of, if you are going to go down this path and you want to put your data together, we need to think about which data you need, what sources of data, which data sets those data come from, which variables you want, what that looks like, what is it that you need in the end. And then more recently, we've just launched a common data access request form. So this is like a really big step. So there's a lot of governance processes around access to data that we can't directly control. But what this common data access request form now means is if you want to do a study in BC, Manitoba, New Brunswick, and Ontario, you would have one form to fill out. We then take the form and work in the background to put the request together into the individual data centers and then do all the shepherding. So you have one point of contact, one form to fill out. It still may take some time for the data to come together, but you're not using your own resources or your own research assistant time to do a lot of that schlepping work. And again, by working together, we're hoping that we can get to the point where some of these systems converge a little bit and become more similar. We're also working a lot on service level expectations, the turnaround times, and pushing where we can to make things better. So this is just if you're interested in working with DASH, you can register, you submit an intake form, you have an intake meeting, and then you kind of go from there. And again, a lot of this can be done prior to putting an application in for funding, and then some of it would happen after you have actually been able to secure the funding that you need to do your project. Okay, so the second piece we're talking about is diversifying and harmonizing data and supporting innovative and privacy-sensitive data use. So you'll see that some of what I talked about, so diversifying data, so the data assets inventory kind of fits into this as well. But what I want to add is a couple additional things that we're working on. So one of the things we've been working on more recently is this idea of the feasibility of developing a common data model. So the attraction of a common data model would be that data would be then pre-harmonized. We're doing the background work to say, okay, if you want to measure continuity of care in all of these places, and we want that measure to be consistent across our different jurisdictions, then we can put that into a common data model. Then you can just request the variable and know that people who are expert in the data have concluded that that is a similar measurement that will produce similar information for you. But the thing is that we didn't want to approach this with the idea that there's a single good common data model out there that exists now that is going to serve everybody's needs. It's just not reality to think that and for people who there's the work that CNODES has done or the OMOP and Odyssey groups, but they're very much tuned to particular kinds of interests and particular kinds of research. So we wanted to think about this common data model project from the perspective of how can we, in the end, use the data that we have in our understanding to produce any common data model that might come forward. And so what we've been working on is this idea of an information item layer in between. So we're not coding the data to a particular model, we're understanding the data, putting all sorts of work into this middle layer that then itself can transform into the models that people want to. I mean, I could explain that in more detail for anybody who's interested, but the basic idea here is this allows us to be infinitely flexible and efficient with the way that we would actually be able to produce common data models, or augmentations or extensions of existing common data models. So for example, none of the ones that we've been looking at or working with have much social data in them, and we recognize that a lot of people want to add that, so that could be an extension by thinking about how we harmonize social data. And then, of course, we're working on partnerships in this, because what we ideally are going to be doing is setting ourselves up so that we can do multi-regional research in Canada, but then we would immediately be able to say, okay, now we're ready for international collaboration as well, because there are international groups that are using some of these models. Another thing that we're looking at is looking at a learning series on the state of the science of federated analysis. We recognize that it's going to be a long road before we could think about and maybe never get to the point of being able to put all of these data into a single location, given privacy legislation, policies, and that sort of thing. But the technology and ability statistically to do really robust research without having all the data in one place is coming a long way and pretty quickly. And so we really feel like it's important to put something together, and that's what we're calling this learning series. So a series of webinars or events that will help us understand what we're actually able to do now and where we should be putting our strategic priorities to help support researchers to do really, really high quality analysis even when the data can't live in the same place. So we're going to start with webinars that are going to be rolling out this fall. We're just putting a group together to think about the topics and speakers for this. And then we hope to be able to end with a hybrid event of some sort that will try to coalesce everything and then think about advice to us and advice to other groups that might be able to help move this forward expeditiously. And then, of course, we probably need to advocate in some way for particular kinds of tools or policy changes or that sort of thing to make this all happen. So I put now the next two pieces together. So one of our objectives is strengthening data use to improve equity and support Indigenous-led data sovereignty. And another is to establish and strengthen partnerships and provide leadership for evolving data practices. So again, you can see some consonance with what I've already talked about in some of these things. So I just want to really focus just a little quickly on some of the equity aspects of this. So one of the things, and all of these conversations are evolving with the focus on race-based data and all of those things over the pandemic, and just recognizing that our use of routinely collected data comes with a certain responsibility to use them appropriately and understand what's represented and not represented in those data. There's a really interesting short book available that's called Raw Data is an Oxymoron. And it's a cute title, but it actually really, really resonates with me, because this idea that, oh, we're getting our raw data and working with it. No, somebody decided what data to collect. Somebody decided to put systems together that either include or exclude people. So there's a lot of power and a lot of other structural dynamics into the data that we call routinely collected raw data. They're not raw. They're cooked already in some way, and we really need to bring that idea to our practice. So if we have, and I'm in the province that was where the In Plain Sight report was written. It's very clear we have lots of racism and systemic bias in our healthcare systems. If that's the case, then the data that we get is going to reflect those biases. And a lot of times I think we think about trying to analyze those biases out, but in many cases we should actually leave them in, because they tell us something about how well our system is working, not working, who's excluded, who's marginalized, and what the experience of different kinds of people are. And all of this, of course, has an implication for health and health equity. So this is a really, really important piece of what we're doing, and it's the part where we think, actually, we need to do a lot of training with existing health researchers to make sure that they're thinking about these things and bringing that some of that practice into the way we're using data. Our focus is on IDEA, and this is the work that Amy Fryer's leading. So IDEA being the inclusion, diversity, equity, and accessibility. And the approach of IDEA, it orients us to justice, but it also requires us to actually take some action like I was just discussing there. We purposefully included accessibility because it's often left out, but actually a lot of people, you'd think about physical accessibility and how that might be able to, or might influence what services you can get access to, that sort of thing, your ability to participate in society, but also the way we design products, the way we write things, the way we design websites also has, for people who have visual acuity problems, really determines who can have access to information and not. There's also auditory things. There's just a lot to think about in making sure that we're being very inclusive in the way that we design all the services and things that we're doing. And just to be clear as well, we're thinking about this both in our own internal activities, but also then how we actually help the research system encompass these ideas as well. So we have 30 members of the IDEA team working together now. They've been working a lot on building capacity and sharing information, just trying to get a sense of what everybody and all of this, there's a lot of activity in this space, but we're trying to bring it together into something that sort of takes the best of all of these ideas and brings them forward. And ultimately to produce training or resources or whatever is needed, but really fundamentally to shift the culture of the way that we're doing things. To date, there's been a lot of engagement with our member organizations and some external groups as well, the formation of the team, creation of definitions and principles, including how we define inclusion, diversity, equity, and accessibility, the asset inventory and an environmental scan. And then what's coming is going to be the development of a strategy for this space, a disaggregated data learning series, so that's another place where we really think that the sharing of knowledge and information is really important. And then trying to see, if we're talking about trying to change culture, what does that look like? How would we know that we're successful? How would we know that we've been able to make a difference there? And I just want to say that there's lots of other principles and practices that we need to think about. This is something developed by the Global Indigenous Data Alliance on in addition to the OCAP principles that are in use in the First Nations communities in Canada, and that needs to be paired with our notions of open science and the FAIR principles of making data findable, accessible, interoperable, and reusable. So these things all need to fit together, live together, to produce a really relevant, thriving, and respectful ecosystem. And then I mentioned very briefly, we received funding from CIHR to work on one of the training programs for clinical trials. So this is a pragmatic trials training program. And it is part of this giant CIHR $250 million investment in that space. And it's specifically aimed at people who are wanting to use routinely collected data for their trials. And the training is going to be on-the-ground pragmatic training. So the idea is by the end of the training, you will have a protocol that is ready for submission to CIHR, another funder, that you could hopefully then get the funding and then do the trial. And this is going to be open to faculty, to postdocs, and to highly qualified personnel who might be support people for methods development and other kinds of, so not faculty level, but people who might be research supports in one way or another. So that includes highly qualified personnel at our member data centers and others as well. And this is connected to the larger clinical trial platform. And again, there's more to be talking about if there's interest in that. The last, and I'm almost now done, we do want to ensure ongoing public and community involvement. Like I said, I feel very much that this is a value we have to live with, helping communities have a say in how we shape the data systems of the future, and in our cases, the rules that we use for who can have access to data, under what circumstances, and for what purposes. So this is our Public Advisory Council. Frank Gavin is the slightly larger picture on the top there. He's the chair of our Public Advisory Council. There's 13 members, a very diverse group of people from across Canada, and they provide us with advice on priorities and projects that we need to do. And they have a communications interest group because the transparency and plain language about data is one of the things that they've been talking about a lot. They meet about 5 times a year, one time in person, and one of those times was actually this week here in Winnipeg. One of the things that they helped direct us to work on was this idea of identifying what the social license is for uses of health data, and just kind of getting a report on public perspectives. If you know this literature, what you'll see here is that this is very consistent with what we've seen in research in other places. But the idea is that people want health data to be used as long as there's appropriate guardrails. They get very, very nervous when we think about selling data. I know that we charge for data in some circumstances because it helps fund our data centers, so we need to really be careful in thinking we're not giving the data away, we're allowing people to license or access, so more like a temporary access rather than a permanent giving away of a resource. And there's certainly not consensus at this point, and at least with the public that we talked about, on uses of data by private company or on uses of data that come from systemically marginalized populations, because it just feels like there's a lot of risk there and we need a different set of rules around that. This was an event that we had this week, Health Data for All of Us. We had about 150 people online and about 40 people in the room just going through some of the same things we've been talking about here, thinking about what the priorities should be, and we're planting some seeds for further conversations about where we collectively want to take the health data space in Canada. Oops, wrong way. Okay, last slide. So what's next? I would say if you're interested, watch for the webinars from our Data Access Support Hub, the webinars that will be coming on federated analysis, on from the IDEA team and so on. There'll be, I think, an increasing number of things that we'll be putting forward in that space. You can watch for recruitment for that pragmatic trials training program if that's of interest. Please provide your input if you're really wanting to do multi-regional research and just not sure whether we're providing the things that are actually going to help you break down the barriers that you've been facing. And you can sign up for our newsletter, which will give you on a monthly basis a bunch of information of things that are going around on the network and new advances and all that sort of thing. So that's the end of the formal presentation, and I did leave some time, so thank you.
Thank you so much, Dr. McGrail. So just by way of context, online we have roughly 50 individuals. So we're going to go back and forth in person and online for questions. I do ask that you come to our microphones here so that the folks online can hear your question, and we don't need to repeat it. So I'll turn to the in-person group first, and then we'll go up and ask for questions online. So, Dr. Dope.
Thanks, Nathan. Hi, Kim. That was great. Thank you very, very much for this. Sorry. My question is, so we went through this as a, not us, but as a group of us went through getting data from another province or trying to get data from another province, and it would have been great to have this organization to support, getting data that are comparable in fields, and are we comparing apples and oranges? And so the problem we had, it took 18 months to get the data organized, and then legal got involved. And so we ended up having to wash the whole thing. It cost us a lot of money because legal from the province, they wouldn't come on board at the beginning. They wanted to see everything. They made us do 2 years of work and then said no. And so I guess my question is, what is this organization doing around those types of things so that when everything is set up, the same problem doesn't happen?
Yeah, it's a great question. Can I assume that you were wanting to pull all the data into a single location?
Yeah, it was bring it all to the same.
Yeah. That's just I don't know how to solve that barrier. It's an enormous barrier, and it's I'm not sure it will be solved, and particularly as provinces and territories are, as I view it, exercising their own data sovereignty, and I can be sympathetic to that, because if you have highly sensitive data and you send it even to a trusted place like Manitoba Centre for Health Policy, the fact is that once it's out of your custody and control, you have lost the ability to draw that data back if something goes wrong and that sort of thing. So that's one of the reasons that we're working on this federated analysis sort of thing, is with the idea that perhaps we can get to a point where there's technically a way like what David Ford in Wales calls an embassy model. So you could put your data in a technical space where you still have custody and control over it, but it can be used in a way that's pretty, I would say, elegant in the way that we actually do the analysis. So that's one thing. And then the other thing I would say is that when you're working with the DASH, we know very well what is allowed and not allowed, and we will absolutely circumvent asking. Like, I know it's frustrating. I know we've had some frustrating conversations with researchers who want to do things, but we're just very clear that's not allowed right now. It's better to know that now than 2 years from now, right?
Yeah.
So we can provide that service for sure.
Okay, thank you.
Are there questions from online?
I don't see any, oh, I do hear my voice echoing. We also can't see Kim. I don't know if it's possible for us online to see Kim, but no, there's no question so far. I'm happy to ask a question because I do have one, Kim. Really fantastic presentation. So much that HDRN has been doing. I'm just thinking in terms of the Canadian Health Data Strategy and the Learning Health System that you talked about. And research is just one piece of that. I mean, of course, a really important piece, but one piece of that. And I wonder if you know, or whether you can, whether they're sort of comparable to the Health Data Research Network, a network that's talking about pulling together data for clinical care provision or health services.
Yeah, that's a great question, Marnie, and so part of this was embedded in. You will have seen all the negotiations between the federal government and Minister Duclos and his provincial and territorial counterparts, and the bilateral agreements that came forward, and some additional investment in 2 ministries of health. So that's one pocket of things. They actually, as I understand it, had to commit to the principles of, I'm not sure I'm going to say that they were the principles of the Health Data Charter, but they were similar principles. They had to commit to those in order to have those negotiations for bilateral agreements. So there is generally commitment, as far as I understand it, across the country for those principles that I went through at the beginning. So that's one piece. I was the one who was making a very strong argument through all of the expert advisory group, trying to put myself on a limb sometimes, saying if we put all of the money that is meant to make this happen into ministries of health, it will not get done. And that's really, I do not mean any denigration to our Ministry of Health colleagues, but they are responsible for, let's say 70% of healthcare service delivery, because that's about it's the public cost. And if we really want person-centered care, I care about the private funded stuff as well. And I care about the things that the ministry does not have data for and will not have data for, the private insurance coverage. All of those things need to come together. So we need to be investing in those other parts of the system and then work collectively towards these health data charter principles. So, and I think what I read from the budget is that $505 million that was not part of the pot of money that was given to provinces and territories, but was left for what they called CIHI, Infoway, and other federal data partners. That's what that money is going to help do. So I think some of it will come through Ministry of Health action money, and some of it's going to come through perhaps CIHI and an increasing role for a different kind of a role for them, where they might be coordinating a larger group of people to do things, not just more CIHI money to do more CIHI things. So I think the vision and and particularly the vision about how we execute this has changed a lot. And knock on wood, we've got a window of opportunity until the next election to really get something in place that is cemented enough that it won't be undone no matter who gets elected next. So I hate to bring politics into it, but that's the reality that we live in now. So I hope that answers the question. It's not clear, but I think there's a commitment.
Yeah, thanks, Kim.
We'll go to the room. Are there any questions?
Malcolm's itching to go ask another question.
Is there another, oh yeah. The whole clinical trial stuff is really cool. Is part of this, using the data we have here, if you're doing something in May, that's great. because we get the data April 1st, and so you're a month behind. But if you're doing it in March, it's not so hot because you're 11 months behind. And so is a part of this process, not waiting? I mean, there's a whole bunch of data quality issues tied in with that, but is a part of it more regular updates of data?
Yeah, there's actually it's a great question, because how are you gonna do a pragmatic trial if you have to wait 18 months for something, like, it's not feasible. So there are a number of our member organizations who have already cracked that and have moved to a situation where it's not real time, because when we're talking about administrative data, they're always gonna be a little bit behind, but we're talking like right now, in the centers that have been able to do this, like where are we now? We're in April. You probably could get January data, maybe even February for some things. So there's be a little bit of a lag, but we're no longer tied in many cases to fiscal year files. And this is one of the things of the sharing of our network, is where there are places that we find that haven't made that switch yet. We now have quite a lot of knowledge about how to do it, how it's been done, policies around that we can share, and maybe help encourage more of that to be done. And then of course, we're also working on EMR data, which for some cases and some trials may be a way to bring things in a more speedy fashion. So yeah, I think a lot of this is truly possible.
Thank you.
Go back to online. Is there a question from the online group?
Yes, there is. Amani, do you want to unmute and ask your question?
Yes, thanks, Marnie. I was wondering if there are any resources through HDRN to connect researchers from across provinces and territories.
Could you repeat that? I didn't quite get it.
Sure. So I was just wondering if there are resources through HDRN to support connecting researchers from different provinces.
Do you mean to help find collaborators and that sort of thing in province other than your own? Is that what you're asking?
Correct.
Yeah, I think we have an increasing knowledge of, and a lot of researchers within the network. So if you are interested in doing a multi-regional study and need to find a collaborator who has some similar interests, it's absolutely something that you should bring forward to the DASH, and we would be happy to help with that for sure.
Okay, thank you.
We have time for one more question. So turning back to the room here, is there another question from the audience? If not, I'll ask a question.
We have one online here,
that,
Nathan.
there's been a lot of work around the Public Engagement Committee, and I'm wondering if, in addition to the idea of the public good for research, what have been some of the other big ideas that have come out of the Public Engagement Committee in terms of health data research, and like what should we be thinking about that here within the context of Manitoba in terms of engaging with the public?
Yeah, I mean, it's very clear both from our conversations with our Public Advisory Council and existing international literature that people really want a lot more transparency about what's going on. I think we have a reasonable amount of kind of push transparency on websites and so on, but there's probably a lot more we could do to actually, and this maybe kind of relates to health data literacy, is how do we bring the public into this conversation? I'll put my cards on the table. I don't believe that the future is that all of us need to be managers of our own health data in all cases and situations. Like, I don't have time for that. That's not my interest. But I would really sure like to know who is worrying about that, what their responsibilities are, how they're going about it, and it's that kind of transparency I think we really need to work on. I also think that there's just there's so much change and uncertainty. Like I'm part of an international group on the Global Partnership for AI, and we started having these conversations like, what does data governance even mean in a context of artificial intelligence? So there's just so much churn that we need to keep up with that. And I will say, lastly, the other thing that the public has been clear about is they would like those consent forms and statements about the way your data will be collected to be far more digestible and clear. So this kind of plain language, can you summarize and 5 clear statements, the way that you're protecting my data, who you're sharing it with it, and under what circumstances, because nobody's gonna read those 47-page documents and understand them.
Thanks so much. I know there's at least one member of the REB that's here in the audience, so maybe that could be taken back to those discussions. Thank you so much, Dr. McGrail, for coming and speaking to us. This was a fantastic opportunity to hear about all of the advancements. Really exciting space to be working in. And thank you to everyone for coming out. I'd like to end with a round of applause for Dr. McGrail.